Good day. I'm Dr. Joseph Leventhal. I'm the surgical director of the kidney transplant program here at Northwestern Medicine. And today I'm going to talk with you about living kidney donation. Living kidney donation relates to kidney transplantation. Kidney transplantation has become firmly established as the therapy of choice for individuals whose kidneys fail and develop what's known as end-stage renal disease, or ESRD. The problem is that the number of patients with ESRD on the waiting list greatly exceeds the number of deceased donor kidneys that become available every year. Going back a couple of years to 2018, we had close to 100,000 people on the waiting list nationally, close to 4,000 people in Illinois, but only around 14,000 deceased donor kidney transplants were performed, and a smaller number of living donor kidney transplants. So this tremendous gap between the number of people who need a transplant and the available of organs that we get from deceased donors is where we believe living donor transplantation can make more of an impact. Increasingly, living donors will be the only way for some individuals to get access to a kidney transplant. And so I'm pleased to talk with you about living donor transplantation and living kidney donation today. Why living donor kidney transplantation? Well, there's the increased realization that the growing needs of patients with ESRD cannot be met by the deceased donor organ supply. The only way to avoid a prolonged time on the waiting list is a living donor kidney transplant. To put this into stark numbers, the average waiting time now in Illinois for a deceased donor kidney is in excess of 7 years. Individuals who are starting dialysis today have a 5-year life expectancy of less than 50%. And so if you're going to wait for a standard deceased donor kidney, you have a better chance of being dead than being alive if you're waiting for that deceased donor transplant. That's where living donor transplantation comes in. With a living donor, it's not a matter of years that you have to wait, but a matter of weeks or maybe months to work up and evaluate a suitable living donor and the recipient to make that transplant happen. Also importantly, we have the best results with a living donor transplant compared to best matched deceased donor kidneys. They last the longest. And there have been advances in how we can perform the operation to allow a person to be a kidney donor. Laparoscopic kidney removal can be done minimally invasively or laparoscopically, which is very, very safe and easy and only requires an overnight stay in the hospital for most donors. This laparoscopic or minimally invasive donor nephrectomy procedure was pioneered in the Midwest here at Northwestern around 23 years ago, and it offers less postoperative pain, a shorter hospitalization, smaller scars, a more rapid return to normal activity, and improved cosmesis. If you're concerned about how the scars are going to look, they're going to look better with the laparoscopic approach. Now, who is a candidate for donation? Well, there are many individuals who are considering kidney donation, many more than actually who are able to donate. The bar is set very, very high related to the medical and psychological health of the individual who wants to donate. And very importantly, these individuals have to be willing volunteers. There can be no coercion. And so a psychosocial evaluation is quite important. There is an individual known as the independent donor advocate who focuses solely upon the needs of the donor as they go through the evaluation process. Very importantly, there is a misconception that a living donor needs to be very closely related by blood to the transplant recipient. This is a myth. Blood relation is not required. In fact, if there's an incompatibility between the donor and the recipient, we have special programs here at Northwestern, our so-called kidney pair donation program, and a program to remove antibodies known as desensitization that can help us make lemonade out of lemons, take individuals where there's an incompatibility and make that transplant happen. Donors have to be healthy. They have to not have certain health conditions that we know can increase the risk of kidney failure during their lifetime or put them at too great of a risk in having the operation. They have to have two relatively normal equal-sized kidneys, and we determine this on an imaging study known as a CAT scan. And the blood vessel anatomy of the kidneys needs to be favorable so that it is safe to remove the kidney and safe to sew the kidney into the transplant recipient. All phases of the evaluation need to be completed by the donor, and very importantly, the family members and support system of the donor need to be agreeable to the idea of the individual donating. So who can get a living donor kidney transplant at Northwestern? Well, anyone who's medically approved and has end-stage renal disease to be a transplant recipient. We can do these transplants before an individual starts dialysis, what we call preemptive transplant, or in individuals who are dialysis dependent. There are various phases of evaluation for individuals who are interested in being kidney donors. The first phase, many times, is an information session that takes place in person at our transplant center. At that time, individuals can fill out in person a health questionnaire, or in lieu of coming in for an in-person visit, people can fill out through the website shown on this slide, www.nmlivingdonor.org, an electronic health questionnaire and get relatively quick feedback on whether or not they've passed that initial health questionnaire screen. Once that health questionnaire is received and approved, it is ultimately reviewed by the team and there's contact made with the potential living kidney donor. Following that initial contact, there will be a visit with the transplant team at Northwestern Memorial Hospital. And this team includes a variety of individuals, including a physician who's focusing on the evaluation of the kidney donor, the independent donor advocate, who is a social worker who focuses solely on the donor and making sure that he or she is doing this of their own free will and has their questions answered throughout the process, and other members of the team, including the transplant nurse coordinators, pharmacists, dietitians, a full evaluation of the individual. Many times this evaluation will involve, at the time of the phase 2 evaluation or leading up to the evaluation, if individuals are of a certain gender and age, cancer screening that is required for appropriate evaluation of the potential kidney donor, and any records that may be required related to health conditions that might have been disclosed on the health questionnaire. On the day of the in-person evaluation at Northwestern, we perform a more detailed measurement of kidney function known as a GFR study and a detailed imaging study known as a CAT scan if no medical or psychosocial issues are identified. There is then a multidisciplinary team discussion following the visit. If the donor is approved, we then reach out to the donor and recipient about scheduling a date for the living donor transplant surgery. That is preceded by a preoperative visit where we do some final necessary preoperative testing and education before proceeding with the electively scheduled living donor kidney transplant. Now this slide I'm showing you to make a very important point, in that after the first initial phase of the evaluation, perhaps the information session, and certainly after we receive your health questionnaire, as we begin talking with an individual who's a potential kidney donor, all the information and conversation that we have with you is confidential. We are not disclosing details of this evaluation to the recipient or other individuals due to HIPAA privacy-related concerns. As we move through the evaluation, as shown here, which can involve some initial blood typing and cross-matching, that age and gender-appropriate cancer screening, which I mentioned. Very importantly, this is not testing or screening that we do for you as part of a donor evaluation, but is expected to have been done by you as part of your general health wellness, and we need to obtain this important screening from you in order to continue to move through the evaluation process. As we go through the evaluation, there may be medical issues which present themselves which would cause us to rule an individual out or psychological issues which present themselves. Or as we go through the evaluation process, you as a potential donor may choose to terminate the evaluation process. Again, you are making an informed, voluntary choice in being a kidney donor. You are having an operation that you don't need to have that's entirely for the benefit of another individual. Yes, you're giving that person a new lease on life, but it needs to be something that you're making an informed, voluntary choice to do. If you choose not to proceed, we can provide a medical excuse at all phases of the evaluation to allow you to remove yourself from the evaluation process without disrupting the fabric of your life and interactions with other individuals. Ultimately, this evaluation process is completed, and we move to the operation, the living donor kidney transplant, with the living donor operation preceding the transplant procedure. Now, this idea of making an informed choice means that we're providing you information about risks to you as a donor. There are also risks to the recipient in having their surgery, and outcomes which aren't necessarily guaranteed to be perfect, but we know we do have excellent results, excellent, close to 99% patient and graft survival. We provide information about potential benefits to donors and those to the recipient, alternatives, and then, of course, there are unknown consequences which can potentially occur. But this is all information that we discuss with you, and we'll talk about some of this as we move through the next series of slides. So what are some of the important facts for potential donors to know? Well, first and foremost, although this is a very, very safe operation, there is a risk of dying from the surgical procedure. It is extremely low. It has been studied for decades, and the risk of dying from this operation is 0.04%, so less than 4 in 10,000. Less catastrophic than you dying from this operation, which statistically is very, very safe, would be that you yourself could develop kidney failure requiring renal replacement therapy. Again, this is extremely, extremely unusual. The need for dialysis or to receive a kidney transplant, and this has been studied for more than half a century, is somewhere between 0.1 and 0.5%. So again, extremely, extremely unusual. An important point that donors should keep in mind is that because you gave the gift of life to someone else, if you happen to be in that very small percentage of patients that during their lifetimes does develop kidney failure, you get priority on the waiting list for getting a deceased donor transplant because of the gift of life you gave another individual. You're not waiting years to get a great kidney. You're waiting a matter of weeks or perhaps months to get that transplant. Now, there have been some follow-up studies looking at living donors showing again that the risk of kidney failure is exceedingly low. A more recent study published over 15 years showing the risk to be, again, a fraction of a percent, 0.3%. At Northwestern Memorial Hospital, where we've performed more than 3,000 laparoscopic kidney removals since 1997 up until 2019, there have been no mortalities. The most common surgical complication that we have seen from living donors has been abdominal bloating and distension, something known as an ileus that can limit dietary intake and become significant enough for us to reevaluate you down here in our clinic at Northwestern in around 4% of patients. What are some of the other risks to the donor? Well, during the evaluation, there can be a reaction to some of the material we use, contrast to do the imaging studies. We might identify or discover certain reportable infections or medical conditions that will require additional evaluation and follow-up. We might discover certain aspects of genetic findings with you as a living donor that we were not aware of because of testing that is warranted to consider you as a potential donor that then would be discussed with you. And there may be, as I've mentioned, certain abnormalities that will require additional testing that will require you to seek out your physician and have that testing done at your own expense. This may also create the need for certain unexpected decisions on part of the transplant team about your suitability as a donor. Now, after donation, with us removing one of your kidneys, it stands to reason that you're going to have some permanent loss of kidney function. What we know about living kidney donation is that the remaining kidney will pick up some of the function of the kidney that was removed. And so living donors will have, on average, around a 25 to 35% permanent loss of kidney function after donation. But we carefully screen donors to make sure that their kidney function will always stay within the quote-unquote normal range and will never have signs and symptoms of kidney insufficiency. Part of the evaluation process is to rule individuals out who in fact have those potential issues, because it is, of course, too risky then to let them donate a kidney to another individual. Now, for women who get pregnant, there has been described a statistically increased risk of certain conditions such as diabetes and hypertension and preeclampsia in pregnancies after donation. And ultimately, if we make a decision that we cannot consider you as a donor at our center, you can be seen at another transplant center for a second opinion. So what about the donor procedure, the operation? As I mentioned to you, it's minimally invasive surgery. It's same-day admission surgery. If we schedule your transplant, living donor transplant to take place on a Thursday, we admit both the donor and the recipient early on Thursday morning. The operation to remove a kidney is with you entirely asleep, what we call general anesthesia. During the time of the operation, after you are completely asleep, we'll place a catheter to monitor urine output known as a Foley catheter. The operation takes 2 to 3 hours, and in 98% of cases, individuals are feeling well enough the day after surgery to be discharged to home on oral pain medicine after having controlled the pain with some intravenous medication for the afternoon and night after surgery. With living donor transplantation, the donor has his or her operation first, and the recipient surgery follows thereafter. There are 2 separate teams of surgeons with a quarterback, if you will, for the donor operation and one for the recipient operation. We have a robust team of surgeons here at Northwestern. Here's a list of the surgeons who all work together here at Northwestern. There are currently here at Northwestern a platoon of surgeons, some of whom perform the donor operations, some of whom perform the recipient operations. Currently, Drs. Borjas, Christopher, myself, and Ladner perform the majority of donor operations, with the remainder of the surgeons sharing responsibility for the recipient procedures. And depending on the day of surgery that you elect to have your operations, that will determine who your surgeons are for a particular case. During the donor procedure, we will generally remove the left kidney if we have our choice, because the blood vessel length and anatomy is more favorable for removal of the kidney and placing the kidney into the transplant recipient. We have you lying on your side down, the side that we're not working on, and then make a series of maybe 2, perhaps 3 small incisions, no bigger than a fingernail, along the base of the rib cage, and a somewhat larger incision that we use to remove the kidney. The kidney is the size of a large human fist, and so we have to make an incision around that big to take the kidney out safely without it being damaged. Recovery after the operation, once you go home, is very, very rapid, with you resuming daily activities of living right after surgery. This is a cartoon showing you what a kidney looks like, and you can see the blood vessels, the artery, the vein, and then the tube that collects the waste product or urine, the ureter. We have to get adequate length on these structures when we remove the kidney to allow it to be safely sewn into the transplant recipient. And we seal the ends of the blood vessels and the ureter with non-absorbable, non-reactive permanent clips and staples to make sure that these are tight and secure when the kidney is removed. Here's a cartoon of a patient lying on their side for a left kidney donation. You can see these red circles where we would put the ports for doing the operation to free up the kidney with our long, skinny instruments laparoscopically, and an area where we would make the incision, the larger incision, to extract the kidney with it not incurring any damage. And here's an actual picture from the operating room showing the laparoscopic camera where we put a port to allow a hand to go in to assist in removal of the kidney, and a cartoon of the kidney up underneath the rib cage. The operation is done usually with an assistant, as shown here. Here's the head of the patient up over here. And again, this is a 2 or 3 hour operation that's done with this video-assisted laparoscopic approach. Now, after surgery, there is some discomfort, most commonly in the area of the incisions. It's also common for patients, due to irritation from the air that we use during the surgery to create a space within the abdomen for laparoscopic surgery, to have some temporary shoulder discomfort. We do some blood testing while you're in the hospital, but we have you walking and resuming a diet the night after surgery. Your Foley catheter is removed the morning after surgery, and if there aren't any issues with your pain control and ability to walk around and to keep yourself hydrated with liquids, you'll be discharged to home the following day. We generally want you off for 2 to 4 weeks from any strenuous activity, no heavy lifting for about a month. And there's routine donor follow-up where we see you a week, 6 months, a year, and 2 years after donation. This is mandatory donor follow-up that all living donor transplant programs conduct and carry out with their kidney donors. Are there certain potential medical complications? There are. Conversion from the laparoscopic or minimally invasive approach to a traditional or open approach is something that occurred more commonly in the early days of the laparoscopic procedure. It's quite rare. It has occurred in less than 1% of the 3,000 plus procedures we have done here at Northwestern. The ileus or slowing of your bowels, which can make you feel bloated, is something that we see not uncommonly in around 4 to 5% of patients. A wound infection can occur with any surgical procedure and occurs in around 1 to 2% of patients. Blood loss requiring transfusion has been quite rare. Only in one of more than 3,000 individuals who have been have had the living donor operation here at Northwestern. And death, which I referred to earlier, which is very rare, less than 0.04% based upon reported experience, has never occurred in the Northwestern experience. There have been no mortalities with our laparoscopic live donor program since it started back in the late 90s. Now, beyond medical complications of the sort that I've mentioned, there can be other complications. There can be psychological adjustment issues for the donor following this operation. Donating can sometimes affect your interpersonal relationships, and there may be, in certain individuals, employment, travel expense, and insurance effects. And fortunately, there are living donor assistance programs and resources available for donors currently that will help soften any potential blow related to these financial impacts that may occur in certain individuals who are stepping forward to donate. In terms of a tangible medical benefit to a donor, there really is none. Beyond the satisfaction of you knowing that you've helped another individual and given them a new lease on life of a transplant, there is no specific donor medical benefit beyond perhaps our identifying an unknown medical condition during your evaluation that we then can act upon. But in terms of consistent medical benefits, there really isn't one for you. It's you stepping forward to do something amazing for somebody else. Are there alternatives to you being a donor? There certainly are. If you choose not to donate or are told that you cannot donate because of issues that emerge during the evaluation process, the recipient can reach out to other potential donors, or if other donors have stepped forward, we can move on to other donors to be evaluated. If there aren't any other donors, the recipient can wait for a deceased donor, and if they've not yet started dialysis, they can initiate and wait on dialysis. More recently, we have established the Living Donor Champion Program, in concert with our patient organization known as the Transplant Village here at Northwestern, this champion program is designed to help individuals who cannot donate to help an individual find a donor. It meets every month here at Northwestern, and it helps give individuals the tools to talk about this comfortably and to help more successfully identify potential donors for an individual in need of a transplant. Just to talk a little bit about outcomes in transplant recipients, this is data that is important, we believe, for donors to have access to. Our one-year patient and graft survivals here for living donor transplantation are excellent, in excess of 98% at the current time, and the specific data is available on the Scientific Registry of Transplant Recipients website shown for you on this slide. Data is not compiled specifically for donors, but if you have specific questions about donor outcomes, you can certainly discuss this with the transplant nurse coordinator who is working with you during the evaluation process. Again, in terms of alternative treatments for the recipient, we've talked about the potential availability of deceased donor transplantation. It needs to be acknowledged that a transplant candidate may have risk factors that will increase their likelihood of having complications after a transplant that are not specifically disclosed to a potential donor. And there are unpredictable variables related to how recipients will do after a transplant, obviously, that cannot, as I've mentioned, be predicted. If there are specific questions about the performance of a transplant program, one can obtain this information from the United Network of Organ Sharing, or UNOS, as indicated on the slide. So what are your next steps? Well, if you're interested in being a kidney donor and have not yet filled out a health questionnaire, we encourage you to do so. The easiest way to do this is to go to the website www.nmlivingdonor.org and upload your information. Talk about your desire to be a kidney donor. It's important that you share this decision and don't do it in isolation of people who play a significant role in your lives. There is the independent donor advocate at the number as shown on this slide you can contact with any specific questions that you have about your evaluation as you move through the evaluation process. So I'd like to thank you for your time with us today and look forward to seeing you here at Northwestern Memorial Hospital if you begin a journey as being a potential kidney donor. Thank you.